think it's final time to start our third session of EuroBloodNet's topic on focus cutaneous lymphoma program. If you have any questions during the presentation, please write it in the chat with a cloud symbol. So today we will have two presentations provided by Professor Pietro Quaglino and Professor Martine M.Bagot. I will start with the order of the webinar. So first will be Professor Pietro Quaglino, who is Associate Professor of Dermatology at the Department of Medical Sciences, University of Turin Medical School. Professor Quaglino is also Director of the Residency Program in Dermatology. Main clinical research interests of Professor Quaglino are cutaneous lymphomas, melanomas, and immune dermatology, with the focus of early diagnosis and treatment. He's past chairman of the EORTC Cutaneous Lymphoma Task Force and is a member of the many prestigious boards, including the board directors of the ISCL. Professor Quaglino authored more than 200 scientific papers and is editor and reviewer of international dermatology journals. So now, Professor Martine M.Bagot, she is a professor of dermatology and currently the head of the Department of Dermatology in Saint-Louis Hospital in Paris. Professor M.Bagot leads a national reference center and network for cutaneous lymphomas. Additionally, Professor M.Bagot actively participates in international clinical trials in this field. Professor M.Bagot is a board member of many international societies like the European Society for Dermatological Research and International Society for Cutaneous Lymphomas. Additionally, Professor M.Bagot is president of EORTC Cutaneous Lymphoma Task Force, and she authored 604 publications, and additionally, she is a section editor of the International of Investigative Dermatology. So, welcome both speakers, and Professor Quaglino, the microphone is yours.
Yes, thank you, Julia. Good afternoon to everybody. Thanks, Julia, for the kind introduction and the involvement. Thanks to the organizers, and particularly thanks to all the attendees who are with us today. I'm so happy to see a lot of friends. So really have a nice webinar all. And I'm proud to share this webinar with Professor M.Bagot. And that's it. So we'll try to share my screen with you. And next slide should be my conflict of interest. It's, okay, perfect. And now I can start my presentation with the disease definition. And indeed, this disease owes its name to the French dermatologist Albert Sezary, who in 1938 described for the first time this kind of erythroderma with skin and blood involvement by these cellules monstrueuses, I hope to pronounce in the right way, Martine in French, which were after well identified as cerebriform T cells. In the last version of the WHO 2018, thus 8 years after Sezary's first description, and it's an honor, I saw also Rein Willemze within the audience. So after 8 years, the definition of the disease is quite the same. So defined by the triad of pruritic erythroderma, generalized lymphadenopathy, and only the term cellule monstrueuse has been replaced by the more modern neoplastic T cells. And these neoplastic T cells recirculate within the skin, lymph nodes, and peripheral blood, but definitely originate into the skin, thus witnessing the primary cutaneous origin of this disease. From an epidemiological point of view, it's a very rare disease, accounting for 2% of all primary cutaneous lymphomas, which are indeed rare as overall. It's more frequent in male and elderly people and characterized by an aggressive disease course with a 5-year disease-specific survival of 36%. What about the clinical features? The clinical cornerstone feature is represented by erythroderma. So T4 according to TNMB classification, and this is defined as confluence of erythema involving more or equal 80% of body surface area. And you see here some clinical examples, so diffuse erythema associated with scales, skin infiltration, or in some cases, as you see on the right part of the screen, also melanoderma. And therefore, we have suggested to single out these 3 different morphotypes of erythroderma, the erythematous, more frequent at diagnosis, whilst the infiltrative and melanodermic being potentially an evolution of the skin disease. Besides erythroderma, other skin manifestations can be present even if not specific of Sezary, for example, onychodystrophy or plantar keratoderma. You can see these features also in psoriasis, but some of them, like nodular lesions, also with adenopathy, you see here, or the so-called leonine fasces, represent manifestations of advanced disease. And these features are also well summarized in this recent review. It is important to recognize that erythroderma develops rapidly, so-called erythroderma d'emblée, only in a minority of cases, around 30%, while it represents more frequently the evolution of previous lesions such as patches or eczematous or mild erythema, or even the evolution of a previous mycosis fungoides present for a variable time. You see here an example of mild erythema evolving to frank erythroderma in 4-year time. And here a case of a mycosis fungoides patch stage with an evolution into Sezary, and another patient who had mycosis fungoides and showed evolution to Sezary into a 20-year period of time. The relationship between mycosis fungoides and Sezary syndrome is controversial, as they share potential evolution and same cerebriform cell origin, but also show distinct phenotypic and molecular features, thus are now considered as 2 distinct diseases. But again, I'll also share a significant delay in diagnosis. You see here, we recently published preliminary results from our prospective ProClippi study. And here you see that in mycosis fungoides, a diagnostic delay is frequent with a median of 3 years. In this multicenter study and analyzing a large series of Sezary syndrome patients, more than 200, the duration of lesions before diagnosis was even longer, more than 4 years. And the authors reported that 49% of patients had a non-specific dermatitis as the earliest cutaneous signs, and only 25% had erythroderma. And this leads also to the possibility that a Sezary syndrome patient could not present with erythroderma, at least in the first phases, but in some cases also during the disease course as shown in this paper, rendering thus early diagnosis even more difficult. From a clinical point of view, also these patients are characterized by a severe impact on quality of life with dramatic itching and cold sensation. And the disease course is also weighted by an increased incidence of infectious complications. You see here in our experience, 60% of patients, main cause of death in this patient. And in these infectious complications are consequent to the immune suppression associated with the disease itself. and worsened by treatment, mainly chemo. What about histology? Histology shows an atypical mononuclear cell infiltrate into dermis with a perivascular pattern or more diffuse, usually mild to moderate, rarely severe. So usually the infiltrate is less severe than in tumor stage mycosis fungoides, with characteristic epidermotropism, as you see here, but again, typical Potrier microabscesses are not so frequent as in mycosis fungoides. The cell phenotype is T helper postemic memory with expression of skin-omi markers like CLA and CCR4, which is now also a target for treatment. A central memory phenotype, this is in contrast and different with mycosis fungoides. Patients with mycosis fungoides show a skin residence effector memory T cells. And then also there's a frequent loss of CD7, even if not in all cases, and a constant loss of CD26 described by our and other group. And the lack of CD26 is maintained in the majority of cases during follow-up. This is a busy slide, just to show you that around 90% maintain the same phenotype, but 12% of patients show changes during follow-up in their CD26 phenotype, particularly when relapsing after a major response. And these changes in the phenotype are due to cell plasticity and tumor heterogeneity, which is shown in this recent study. The definition of blood involvement, which is crucial for Sézary patients, according to the ISCL consensus, was based on different criteria: morphological, phenotypical, and molecular. We recently, as the ERTC group, suggested a simplification of these criteria based only on flow and confirmed on molecular, and considering absolute count of two markers, CD4 plus CD7 negative or 4 positive 26 negative, B0 less than 250 per millimeter, B2, so blood involvement, more than 1000, and B1 in between these two categories. It's important to classify B score to allow us to differentiate between erythrodermic mycosis fungoides, B0, B1, and Sézary syndrome, which by definition is B2. What about differential diagnosis? It's really a challenge. CTCL and Sézary accounts for 10 to 15% of erythrodermic cases. Thus, differential diagnosis represents a challenge with respect to other more common diseases, such as psoriasis, atopic dermatitis, or drug reaction. In this multicenter ERTC study, we addressed the issue of pathological features which could help in differentiating between Sézary and erythrodermic inflammatory dermatosis. And we found a high expression of CD8 in inflammatory with respect to CD4 in Sézary, and in Sézary a higher PD1 and Ki67 expression with a lower CD7 expression. As to phenotypical features, we ran this further ERTC study led by the Dutch group, always comparing Sézary and erythrodermic inflammatory cases, showing that from a phenotypical point of view, the ratio, the CD4, CD7 negative and CD4, CD26 negative are important for the correct diagnosis, together with the expression of CD158, and I will let Professor Bagot tell about this marker, as Professor Bagot is the leader, and is thanks to the study of the French group who are now able to use and know this marker. We also addressed the issue of molecular markers, whilst even if some molecular markers were identified, overall the molecular landscape of Sézary syndrome as well as CTCL as overall is definitely heterogeneous, thus limiting the potential diagnostic relevance at the moment. So to summarize, to target the correct Sézary diagnosis is important to consider all the different aspects, thus clinical pathology, and in this appropriate clinical pathology context to confirm the diagnosis with the molecular demonstration of the same TCR clonal rearrangement in blood, skin, and hopefully also nodes. After diagnosis, during staging and follow-up, it's important to consider to repeat whenever possible biopsy and check for relevant marker expression, to try to perform node biopsy, particularly in patients with bulky and severe enlargement of nodes. Imaging for sure, it's important, but there is a very low percentage of patients with visceral involvement demonstrated in vivo. Bone marrow biopsy is usually negative, whilst flow cytometry is very informative to diagnose and to follow the patients, and I were to say more informative than the TNMB stage itself, which is in the majority of cases, I mean, per definition, T4 and B2, so it's for A1, A2, or for B in case of visceral involvement. This is always important beyond the patient to investigate the presence of potential donor for allotransplant, particularly if the patient is young with a high B score. What about survival? As I previously told you, survival is poor, 36% disease-specific survival according to WHO. In our experience, 5-year, 28 disease overall survival, median 25 months. And according to literature review, the survival is different according to different 4A stages. So 5-year disease specific from 41% in 4A1, so only blood involvement, down to 18% in 4B. And the same in this recent paper, this is overall survival, 52% down to 23 stage 4B. We have prognostic indicator associated to worse survival. You can read these markers in these slides. We recently analyzed this issue in advanced stage cutaneous lymphoma, including Sézary syndrome as multicenter, and stage 4, age, large cell transformation, and high LGH were found to be independent prognostic variables for worse survival. And specifically for Sézary syndrome, I think that the B score, so the tumor burden in the blood, is really a very important predictor of prognosis in this patient, and also important to consider for addressing the issues of treatment. Last topic of my talk would be treatment. Thus, how do we treat these patients? Standard treatment. M.Bagot will tell you about new treatments and clinical trials. The first-line treatment is represented by extracorporeal photochemotherapy, which is an integrated procedure in which leukocytes were drawn from the patient and treated by photosensitizer and irradiated by UVA, and then reinfused to the patients. And this induces an immune reaction, which is able to induce a clinical benefit in a significant percentages of patients, around 60% in this review, particularly in cases with low tumor burden in the blood. I will present you selected guidelines, for example, EuroTC guidelines as first line, ECP, and then in association we can use interferon or bexarotene also together, or we can use monochemotherapy, gemcitabine, or doxorubicin or methotrexate as second line chemotherapy and allogeneic stem cell transplantation. nearly same indication from the ESMO guidelines as first-line ECP in combination with immune modulators, or also phototherapy or low-dose methotrexate or chlorambucil. So we have to choose which is the best treatment you can do in our patient. And second-line mono chemotherapy or allotransplant, also low-dose alemtuzumab, which is very active, particularly in the blood, but also weighted by severe infectious complications. NCCN guidelines identified and made different recommendations on the basis of the burden in the blood, introducing also some drugs, for example, MOGA or romidepsin, that are not currently available and reimbursed in Europe. And last, I would like to share the indication that we developed in our Italian cutaneous lymphoma group, dividing low tumor burden and high tumor burden. For low tumor burden patients, ECP plus immune modulations. For high tumor burden, chemo, and then after response, hopefully ECP, and relapsed refractory allogeneic stem cell transplantation. But you see here always clinical trial for all these patients. From the guidelines to real life, this is a retrospective study which we performed in Italy on a large series of mycosis fungoides Sézary syndrome patients at stage 4. You see here mono chemotherapy together with ECP are the more commonly used regimens. The same data came from this international retrospective study involving a lot of centers and France. And for stage 4A1, ECP again plus immune modulating or chlorambucil or methotrexate are most commonly used as first line, whilst for stage 4A2 and B, poly, chemo, and ECP again. But what becomes clear from this multivariate analysis performed in this study is that when we consider first-line treatment, it's important to realize that as independent prognostic variable, mono and poly chemotherapy were associated with higher mortality and risk of changing treatment. Thus, the indication are to spare chemo as long as possible to preserve immune status. And just to conclude, these data are in line with the recommendation of ISCL for Sézary syndrome treatment, which I completely agree with. And I will show you as a key point conclusion. So use disease burden and rapidity of progression to determine therapy, preserve immune response, and use immune modulators, particularly in combination, consider potential causes of infection, and preserve quality of life. And that's all. Thank you so much. These are some picture of my town. Thanks, and available for any question from the audience.
Thank you very much, Professor Quaglino.
I will stop sharing my screen.
Yes, please. And now it's time for Professor Bagot. And for all of the participants, there will be discussion at the end. So please, if you have any questions, you can write them in the chat, or you can ask them at the end, also in the writing in the chat. Thank you very much. And please, Professor Bagot, the microphone is yours.
Can you see it?
Yes, perfect.
So thank you, Pietro, for the very fantastic talk. And so I will speak to you about some specific parts of for Sézary syndrome that is more focused on flow cytometry and on new possible therapeutic strategies. So my conflicts of interest. So I will go again on the biological criteria for the diagnosis of Sézary syndrome. As Pietro told you, these are the flow cytometry criteria classical for the diagnosis of Sézary syndrome. Initially, there were either Sézary cells by cytomorphology and identical T-cell clone in blood and skin, and there were also ratio higher than 10 or CD4, CD7 positive lymphocytes in the skin higher than 40% lymphocytes, or CD4 positive, CD26 negative lymphocytes higher or equal to 30%, and of course, an identical T-cell clone in blood and skin. And as Pietro told you, so you can see how in flow cytometry, you see, if you see the threshold, 30% on a great number of patients, you see that the percent of CD4 positive, CD26 negative lymphocytes, here you can see in pre-Sezary syndrome, B2, in Sezary syndrome, B2, in pre-Sezary syndrome, B1, and in B0, erythrodermic mycosis fungoides. And you see that these thresholds allows to identify clearly the patient with the Sezary syndrome. It is very important because in some patients, the histopathology criteria can be questionable, may be difficult to make a diagnosis on histopathology. And in these cases, flow cytometry will be extremely important to do the diagnosis. These are the control, inflammatory diseases and mycosis fungoides. You see that they do not have higher percentages of CD4 positive, CD26 negative lymphocytes in the blood. Here you can see the sensitivity of the search for CD4 positive, CD4 positive 26 negative. You see that there is a quite high sensitivity, also good sensitivity for the flow cytometry using CD4 positive, CD27 negative lymphocytes. And this is a new marker. You see that also using CD4 positive, K3DL2 positive cells, there's also a very nice specificity with using a lower threshold. This is not an international criteria. These are international criteria. And here you can see the correlation. You see that there is quite a very good correlation between the number of TCR V beta cells and the number of CD4 positive 26 negative lymphocytes. Also very good correlation for CD4 positive, CD7 negative, and also very good correlation for this new marker, K3DL2 positive cells. And how now, here are the new biological criteria for the diagnosis of Sezary syndrome on flow cytometry, defined by the European group on EGC. You can see these patients with B0 correspond to erythrodermic mycosis fungoides, stage 3A, Sezary cells less than 5%, and also absolute number of 4 positive 7 negative and 4 positive 26 negative cells less than 250. Stage 3B correspond to pre-Sezary cells, or B1, that is patients with either Sezary cells more higher than 5% and less than 1,000, or absolute numbers between 250 and 1,000. And the real Sezary syndrome, corresponding to stage 4, correspond to Sezary cell higher than 1,000, increased CD4 population with a ratio of CD4 on CD8 gray higher than 10, or increased cCD4 with abnormal phenotype, CD4, CD7 higher than 40% or higher than 1,000, and percentages, CD4 26 higher than 30% or higher than 1,000. So these are very important criteria for the diagnosis of Sezary syndrome. And now we go to the new treatment for Sezary syndrome. As Pietro told you, there are no good treatment for most patients with Sezary syndrome. And so it is very important to develop new treatment strategies. And there is new hope to develop strategies with a combination or a succession of treatment with new antibodies that could also be used sequentially. And there are two types of monoclonal antibodies. Antibodies that modulate the immune response, such as anti-PD-1 or PD-L1 antibodies. And there are many other types of antibodies that try to increase the immune response. And there are also antibodies that try to destroy the tumor T cells. And let's see the first type of treatment, the anti-PD-1 or PD-L1 antibodies. Pembrolizumab has been used in relapsed and refractory mycosis fungoides and Sezary syndrome. This is a study from Werner Kempf in Stanford. And they treated 24 advanced mycosis fungoides or Sezary syndrome with pembrolizumab every 3 weeks. And you see that approximately 1/3 of the patients had a good response. You see that some patients had a complete or partial response, approximately 1/3 of the patients. And these responses were quite prolonged. And so this is quite a low number of patients. And there are also other studies. The European group is doing also a study using anti-PD-L1, that is alizumab. And we know that this treatment, you need the overall response rate is only in 38% of patients. However, for the future, it will be very interesting to combine this immunomodulatory treatment with possibly with other types of antibodies that tend to destroy the tumor T cells. There are also many other trials studying this way. For example, antibodies against CD39 or antibody CD73. That is a new pathway that might increase the immune response in these patients. The other way is able to destroy tumor T cells. And we speak about mogamulizumab. Mogamulizumab is a humanized anti-CCR4 antibody with a defucosylated Fc region. Defucosylation induces an increase in the affinity and the ability of the antibody to induce the destruction of tumor T cells. And you can see CCR4 is expressed by lymphocytes with a homing potential, both normal T lymphocytes and tumor T lymphocytes. And it is overexpressed in ATL. This antibody has been raised in Japan and is approved for ATL, but also CTCL and PTCL. And CCR4 is also expressed by regulatory T cells, FOXP3 T cells. And so this antibody will destroy not only tumor cells, but also reactive cells and also regulatory T cells. A controller study was performed. It was an international open-label randomized control phase 3 trial published in Lancet Oncology 2 years ago. And this study, it was a MAVORY study. It includes stage 1B to 4B histologically confirmed MF or Sézary syndrome. You see that a great number of patients were randomized. It's the biggest randomized trial in the field of CTCL. It was a worldwide trial, 59 centers. And the patients were randomized either receiving vorinostat, that is a histone deacetylase inhibitor, that is commercialized in US, not in Europe. And the other arm were mogamulizumab every week for the first month and then every 2 weeks. And there was a possibility to cross for the patient who had treated with vorinostat and who did not have a good response, they had the possibility to be crossed to the mogamulizumab arm. And you can see the primary endpoint was progression-free survival. And you see that mogamulizumab has a clearly better progression-free survival than vorinostat. And this was a very encouraging result. Here you can see the waterfall plot. You see that in the mogamulizumab, there is quite a high number of patients achieving either CR or PR, and significantly higher than in the group with vorinostat. And so, based on this trial, mogamulizumab was approved both in US and in Europe in 2018 for relapse or refractory mycosis fungoides or Sezary syndrome, having failed at least one prior systemic therapy. What are the side effects of this treatment? In the trial, you see that the main side effects in the mogamulizumab groups were infusion-related reaction and quite a high number of drug eruptions. I will come back to that. Approximately 25% to 30% of patients presented drug eruption. These are the side effects in the vorinostat groups, quite high, mainly diarrhea, fatigue, nausea. And so the side effects seems to be clearly in the balance in favor of mogamulizumab arm. Here we show an example in real life, an example of how they present the treatment. The treatment with mogamulizumab. Here I show you the example of a patient who presented in 2010 with pruriginous erythematous lesions. He had a diagnosis of atopic dermatitis. He was treated with corticosteroids. And after 7 years, he presented with erythroderma, palmoplantar keratodermia, asthenia, and on the biopsy, he had the diagnosis of Sézary syndrome. He presented hypereosinophilia, increased ELDH, identical T-cell clone in skin and blood, and in the CT scan, axillar and inguinal adenopathies, and the biopsy showed invasion of Sézary syndrome, of the nodes by Sézary syndrome. Here you can see example of flow cytometry. You see in flow cytometry, he had 89% of 4 positive, 26 negative cells. He had 3,500 4 positive, 26 negative cells. You see that he had also a high percentage and absolute number of CD4 positive, KIR3 positive cells, a ratio of 13. So he had the real Sézary syndrome, T4 and 3, M0B2. He was treated classically, successfully by bexarotene and photopheresis, then interferon photopheresis, and he achieved only partial remission. And so after 1 year, he progressed a lot. He had a lot of polyadenopathies. You see that the flow cytometry, he had a high, both absolute number of percentage of CD4 positive, CD26 negative lymphocytes. He also had a high number of CD4 positive KIR3DLT lymphocytes. And at that time, a treatment with mogamulizumab was decided, was begun. And you can see that before he had these are the positive Sézary cells. You see that these cells were CCR4 positive. And after 9 months, you see that the tumor cells were very low minority. And you see that CCR4 positive cells had completely disappeared. Clinically, we had first a CR in blood after 3 months. After the blood, he was B0. And after 6 months, he was a complete remission in skin. And now, after 21 months, this patient is persistent complete remission in skin, blood, and nodes. So a very interesting result. It's an example of the patients. What is also interesting with this treatment is you can have a possibility of inducing both autoimmunity and persistent complete reaction. This patient was a Sézary syndrome patient relapsing after 8 prior lines of treatment, including 3 cycles of alemtuzumab, and she had several kinds of autoimmunity, rash, alopecia, hepatitis, vitiligo, thyroiditis, and you can see that this patient has now been in complete remission without any treatment for more than 5 years. You see that he has a vitiligo. And it is interesting because it is probable that a depletion in CCR4 expressing Tregs could activate cytotoxic T lymphocytes and explain these durable responses. And now we come to another type of monoclonal antibodies, recently raised monoclonal antibodies, KIR3DL2. KIR3DL2 is a NK receptor, and it has been shown that this NK receptor, KIR3DL2-CD158K, is expressed by Sézary cells and can be used for the diagnostic and follow-up on Sézary syndrome. You see that KIR3 positive cells are almost monoclonal, whereas KIR3 negative cells are polyclonal. And most kinds of CTCL express KIR3DL2, especially Sézary syndrome. Here you can see the expression in the skin. And so it was interesting to raise a monoclonal antibody in order to have a therapeutic humanized therapeutic antibodies with a selected action of non-tumor T cells. And here you can see that this antibody is named IPH4102, and it binds D0 of KIR3DL2. And preclinical results have shown that this antibody induced autologous ADCC in patients with tumor cells of patients with Sézary syndrome. And so this antibody has been studied in a phase 1-2 trial. And you can see that here is a percentage of patients with 50% decrease of lesions, that is a PR. And you see that quite an interesting number of patients achieved either PR or CR, even some patients having failed previously mogamulizumab. And so this antibody shows also durable responses. You see that patients with durable responses, even patients with only stabilization disease had a stabilization of their improvement. Sorry. I can't. Okay. So interestingly, also there was an improvement in the quality of life. Evaluating, for example, the pruritus, you see that the patient with CR or PR have a decrease of the pruritus, but patient with stabilization disease, that is a decrease of the lesions less than 50%, they also had a decrease and sustained decrease of the pruritus. If you look at the cells in the blood, you see that the aberrant cells can be identified either using 7 positive or 26 negative cells. And you see that there is a decrease of these cells in patients with CR or PR, and also a decrease of the cells in patients with stabilization of the disease. You have the same results if you identify the tumor cells by KIR3DL2 positive cells. You see that the patients with CR or PR have a decrease of their tumor cells in the blood, and patients with stabilization of the disease also have a delayed but significant decrease of their tumor T cells. Here you can see the decrease. You have the CDR positive and the KIR3DL6 positive cells. Here you can see that these cells progressively decrease and disappear from the blood. Again, if you identify the tumor cells by the CD26 negative KIR3DL2 positive marker. And so this trial was published last year in Lancet Oncology, and it was a new hope for the treatment of CTCL patients. And it showed a favorable safety profile and encouraging clinical activity of this antibody named lacutamab as a single agent in patients with relapsed and refractory Sézary syndrome. And based on these results, FDA granted in 2019 fast-track designation for this antibody in managing relapsed and refractory Sézary syndrome, and further phase 2 trials are ongoing. So now we will show an example of a patient treated with lacutamab. So this is a patient who is a 62-year-old, and since 2014 he had a pigmented pruriginous erythroderma. After 1 year, a diagnosis of Sézary syndrome was performed with a histology confirmation. Here you can see the flow cytometry with a high percentage of CD positive 26 negative, high percentage and the absolute number of CD158K lymphocytes, and a high ratio. Scan was normal, there were no node involvement. And this patient also had a failure of several treatment lines, successively bexarotene and photopheresis, interferon. In 2017, he progressed. You see that he had high numbers of tumor cells in the blood. He was at that time treated with lacutamab, and you see that you see a progressive decrease of the skin. And then at week 10, he was in the skin almost in CR. The blood was in CR. You see that he was really a B0. He had an excellent tolerance. He had injection 1 per month. And in July 2020, after 2 years and 8 months, the treatment has been stopped, and he is persistent CR in skin and blood. So these new antibodies are quite interesting because you can imagine that in the future, it would be possible to treat Sézary syndrome with chemo-free regimens. And like in other hemopathies, it would be possible to successively or combine or to successively treat these patients with these antibodies. And it is interesting to show that they may achieve long-term complete remission. And so this might, in the future, change the perspective and the treatment strategies for these Sézary syndrome patients. So there's a take-home message. And so to finish, I will tell you that if you are interested in cutaneous T-cell lymphoma, we were supposed to have an EORTC meeting in Marseille in October 2020. And of course, due to the COVID pandemic, this meeting has been reported to 2021, and we are welcome to attend this meeting in Marseille in June 2021. So thank you, and now we'll take questions.
Thank you very much, Professor Bagot, for this comprehensive presentation. And I would like to encourage participants to ask questions in the chat. Before, I would like to already read some questions which were written in the chat, or maybe I could ask Professor Quaglino, because there were questions dedicated to his presentation.
Okay, can you hear me? Perfect. Okay, yeah, I tried already to answer to the question by writing a few words. Mainly, I think that we're all related to treatment, and I think the best option for first line today is photopheresis, so extracorporeal photochemotherapy alone or in combination with immune modulators. But I have also to say that, particularly in young patients with high tumor burden in the blood, always consider transplant, when planning your therapeutic approach. And we have heard from Martine/M.Bagot that we have now drugs with high activity in the blood, MOGA, and also the new, the anti-KIR antibody presented by Professor Bagot. So always try to consider also for these drugs as potential bridge for a transplant. And ECP is particularly active in patients. I remember a question also in erythrodermic mycosis fungoides and the so-called pre-Sezary. The only thing is that you have to continue treatment for a long time because immune modulation takes time to give benefit. I read another, how long do you wait for alemtuzumab? We had some experience, and also I think Martine/M.Bagot can comment on this, with alemtuzumab, not a standard dosage, but a low dosage, because it's a very active drug in the blood, but with severe complication, infectious reactivation of cytomegalovirus. But the activity of alemtuzumab is really takes very short time to become clear. So I remember cases of patients that develop a wonderful, exciting, amazing response in the blood after 1 to 2 to 3 days after the starting of treatment. So you don't have to wait for a long time. It's definitely immediate.
Can you still prescribe alemtuzumab? Is it available?
We have a nominate use in Italy for selected cases. It's not so easy, but we can have this treatment for usage. But with respect to the past, we use this treatment rarely, and again, sometimes also for bridge for transplant.
We have a question on brentuximab. Pietro, maybe we can answer that. Yes. Is a brentuximab? Brentuximab, actually, yes.
Brentuximab, was not. In the cancer trial, very Sézary syndrome patients were not included as per definition. So we don't have such many data, but we have some real life data also collected within the group that brentuximab can have an impact also in these cases with CD30 expression. In Italy, is now reimbursed for all the cutaneous lymphoma cases with CD30 expression. So it can be also used. In my experience, brentuximab is more active in patients with tumors, so in the skin tumor stage mycosis fungoides, or also in cases with large cell transformation. So I would prefer other drugs, but can be considered also in Sézary syndrome. So it's important to consider all these different treatments and tailor the treatment according to our patients' features.
Yes, I didn't mention brentuximab because in the trial there was no Sézary patients, and most Sézary patients do not express CD30. However, in real life, it is possible to induce a complete remission, for example, before performing allogeneic transplantation. It is possible to induce a CR in blood and skin using brentuximab in some Sézary patients.
Or I can combine brentuximab with other treatments after to improve the response. So there was a question about MOGA and alemtuzumab. I think I don't know. I think that Martine, you presented MOGA. The question was, is better MOGA or alemtuzumab before? I think that MOGA.
I think more because alemtuzumab is a very nice drug, but the patient is completely immunosuppressed.
Yeah.
And so and also it's very difficult to get alemtuzumab now. I think MOGA is very interesting because it works very well, and in some patients it can include very long-term responses. In some patients you can have a long-term response in the blood, and the patient has only a few skin lesions, and so it changes the disease. And so it's a very interesting drug that really induces immune modulation, not only destroys the tumor cells, but also induced immune modulation. So that's quite an interesting tool to treat these patients.
Yeah, there's a complicated question about different population. Yeah, there's great heterogeneity of phenotypes at the same time at different time points of the disease.
Different populations. In our experience, we showed that initially it was said that Sezary or central memory lymphocytes and mycosis fungoides resident memory lymphocytes. Actually, Sezary syndrome are much more heterogeneous, and several teams have shown that Sezary syndrome may also have a resident memory phenotype. They may also have a naive phenotype. And so the disease is much more heterogeneous, that it's not so simple. That's Sezary on one hand and mycosis fungoides on the other hand. All these diseases show great heterogeneity. And also there is a heterogeneity between the skin and the blood. The phenotype may be different in one patient in the skin and in the blood. Usually it's more differentiated in the skin than in the blood. So it's a very great degree of heterogeneity in the phenotype.
Yeah. There was a question on JAK-STAT inhibitors, and I don't have direct experience from a molecular point of view. There's a frequent mutation in JAK-STAT pathways, but I don't have experience in the treatment with these compounds. I would be very interested in having a trial on that and getting some results, but at the moment I don't have experience on these drug compounds.
I don't have either. There is a question on the moment when we think of allotransplant. Actually, if there is low tumor burden, we begin to use immunomodulatory treatments, ECP, bexarotene, interferon. And if the patient is okay, no problem. But if the patient begins to escape these treatments and begins to have more evolutive treatments, and if the patient is young, it is always very important to ask for, there are some brothers and sisters and the possibilities to think about bone marrow transplantation. And if the patient begins to have evolution, very rapid evolution, it is important to think at this possibility not too late during the course of the disease. Because some patients may be really cured by allogeneic cell transplantation. And if the patient is young, has no comorbidities, and a good donor, results can be extremely very brilliant with allogeneic cell transplantation. Yeah. The questions?
How do you manage severe pruritus? Is always a challenge, and this is a very important symptoms which hampers quality of life, and that's important to try to use every kind of drug and treatment that we have. And photopheresis is able also to induce the reduction in pruritus is one of the first improvements that you see in the patient treated by ECP. So that's important, because if I have a Sezary syndrome patient with stable skin and blood involvement, but improvement in pruritus, this is, for me, I think is a very important response. So we should try to incorporate quality of life issues also in our consideration of patient outcome and results. So treatment, and then also phototherapy on the skin can be useful, and also we have some treatments. Antihistamines are not so useful. Low dose steroids can use also systemic, also gabapentin, and also other treatment may be considered for that.
So do you see spontaneous responses, reduction of blood tumor burden? It's always may happen, but it's very rare. It's rare. Usually we do not have, but sometimes we have very good results only with photopheresis. For example, patients may have a very good results and also long-term results. And also some patients seems to have to be a good response after a few years, but usually these are not the most important, most frequent cases of patients. You agree, Pietro?
Yeah. Completely agree. It's important to maintain patients in treatment also for, a long time, and try to consider whatever delay the courses of ACP on the basis of the clinical features, but try always to maintain this treatment as long as possible to preserve the response.
Thank you very much. I think that the discussion is over. Thank you very much for this scientific discussion and very, very comprehensive 2 webinars. And before everybody will go, I have some information to share with you. And first of all, I would like to invite all of you for the next sessions. We still have 6 sessions to go. So please, if you already attended the previous 3 and you would like to receive the accreditation point, remember that you also have to be present at the next 6 sessions. And of course, I would like to invite you all for subscribing to our EuroBloodNet newsletter, so to be updated with all of the actions and initiatives that we are working on. And please follow EuroBloodNet on Twitter, LinkedIn, and Facebook. And also recently we have opened our YouTube channel. It's a EuroBloodNet's Edu, where all of the webinars, also from the topic on focused cutaneous lymphoma, will be publicly available very soon, and we'll keep you updated. But please subscribe so you will receive this information in the first place. Thank you so much, everybody, and Professor Bagot, Professor P.Quaglino, thank you so much for
doing that. It was a pleasure. Thank you, Pietro. Very nice to do the
and have a nice day. Bye-bye.
Bye-bye.
Bye-bye.